Good afternoon, everybody. I would like to thank the organizing committee, myself, for the kind invitation and to express my gratitude. So it will be, I will be talking about the future aspects, about the surgical treatment of valvular disease. So the anatomy and the pathology of all valves is known to everybody. Mainly we treat aortic stenosis or mitral regurgitation. Then the next to come would be the aortic regurgitation, the mitral stenosis, and the last will be the tricuspid valve pathology. In comparison to the transcatheter methods, surgical treatment is known for more than 100 years. It has evolved a lot, and it has tested a lot, and the experience has sum up. So we have mechanical valves used for more than 60 years, and tricuspid, again, the tissue valves used for more than 50 years. Also, apart from the changing the valve, we have the ability to repair it, and this has also started far ago, over 100 years ago, and we have managed to reach at the point where the results of repairing the valve, mainly mitral and tricuspid, are excellent. So what is the future? So there are three main pillars as far as the surgical approach is concerned. Is the surgical approach, are the new technologies that are coming on the manufacturing and the industrial level, and some surgical techniques that I'm going to show you. So the surgical approach, the three first are well established, mainly the two ones. The right anterior thoracotomy and the endoscopic approach now is all around the world well established, but not to all hospitals, but not only with some teams. Transcervical and robotic approaches are still developing. So this is the main approaches, and this is the present approach with the mini sternotomy, the thoracoscopic approach, and the endoscopic view, where we can see an excellent view of the mitral valve, which is a great advantage to the surgical approach. And you can see that we can achieve complex repairs with a ring, with a neocords, and even reducing the excess tissue of the leaflet. The future approaches may be either with the assistance of robotic machinery or with other devices. They are still developing. There are very, very few centers using this technique, but still the future we may have to do with this. But how do we evolve as surgeons? First of all, we have to go step by step. We cannot skip some of the procedure, or some steps of the procedure, and I would suggest that at this point, at the present time, all the surgeons who should be involved in the endoscopic surgery, and then try to make the next step. What are the technologies that we have and we are coming? Already there are some valves that they're advertised that they may last for more than 25 years. The Inspiris valve has already the in vitro test of 1 billion circles that has with a success. That means that if we can project that would be 25 years without problem. That's of course very long time, and we will need still to be find out if it would be true. And there are some other valves as well already being used that can be combined with the minimal invasive techniques, the intuitive valve and the Perceval valve. We have already experienced more than 10 years with the Perceval valve with good results, especially in small roots and annulus. But the bioengineering is evolving. We can, at some point in the future, they believe that we would be able to print valves built by collagen, and it will be custom made for each patient, and with with the ability to shoot exactly at the patient that each different patient. You can see here that there is already been tested, and the pressure that can hold is above the pulmonary and tricuspid valves, but of course there's still some way ahead. Another possible aspect in the future will be the use of polymeric heart valves. In the United States, I have already used this valve in the tria valve in human, not only the aortic side, also in the mitral valve side. And this kind of valve that is polymeric, it means that it's mainly done by material like silicone or Teflon, and it may have they will try to keep the advantages of the mechanical and tissue valves, so you won't have to use the anticoagulation, and but you have durability like the mechanical valves. So, talking about mechanical valves, we should say that we should always keep them in mind. We have already valves that need less level of anticoagulation, but we are already trials checking on the ability on some valves to have different shape and be able not to need anticoagulation at all. This is the TriFlow valve, and the trial has started already from 2023. Some surgical techniques, I will show you 4 or 5 techniques that I had the chance to work with. So the Roussakis technique is a technique when you replace the aortic valve and you use autologous pericardial treated with glutathione on the surgical site, and you are able to reconstruct the valve with great coaptation. It has a minimum stenotic phenomenon post-surgically, and in only some very few cases you can find some minimum regurgitation. On the aortic valve, we already using and they have already implanted more than 1,000 globally. Is the heart valve. It is a heart ring, which is a way to improve the aortic valve regurgitation, even with a large root, and the preliminary results are very promising for the future. The neocord is a surgical transapical approach to put neocords on the mitral leaflet, especially on the posterior leaflet. Already 2,000 of them have been, in 2,000 cases have been tested, and the final results are maybe of the RECORD trial may be published within 1 or 2 years. I would like just to pinpoint the ability to use both techniques with the transapical on the transaortic approach. I had the chance to work with Dr. Bapat at St. Thomas's, and we were using a transaortic approach for transcatheter valve implantation even 10, 15 years ago. This is a good alternative, just with, of course, we cracked the sternum, but we still have good results. The Tendyne valve is another valve we used. We have implanted at my center, at Donasi Center, and we have used the 2 first in Greece. It has a surgical approach. It's a transcatheter mitral valve. It has a great hemodynamics post-operatively. It's very strict in order to be for the including criteria at the moment, but 1,000 of them have already implanted around the world, so we're waiting for the future results, and maybe a good way to treat our mitral valve regurgitation in the future. One last comment. I know I'm over my time. One of the problems with the use of transcatheter techniques in younger and younger patients all over the world is that we will have to face in the future a problem. Maybe we will have to face some problems. The most growing rate, the operation with a growth rate of 6,000% is the TAVR explantation in the United States. It has to do with the meteoric rise of use of TAVR in younger patients. And the thing is that when we will have to deal with this problem, the explantation of the original valve is a very difficult operation, and in some cases you'll have to replace the whole aortic root. This is the same view of the same problem, and we have to be very careful what decisions we make for the management of the aortic valve disease in the young patients. This is to prove that what I'm saying is that already in California, in the state of California, almost 50% of the patients below the age of 60, they are treated with a transcatheter aortic valve, and the results are have some even if the results are 2.5 times higher the mortality than the surgical aortic valve. This is the same. You have over time. I know, sorry. So the future will come, and we'll have to be very careful with our choices. We shouldn't forget the methods we are using up to now, but we have to evolve, get better training, the new techniques, and be always ready to learn new things. Thank you very much.
Thank you very much, Dr. Roussakis. Very difficult job to present all these developments and these realities in a such